Hello, and welcome to the webinar From Public Health to Addiction Treatment, Integrative Harm Reduction Psychotherapy for the Full Spectrum of Addictive and Risky Behavior. My name is Andrew Tatarsky, and I'm an addiction psychologist from New York City, where I'm giving this webinar from. First, I want to express my hope that each of you and your loved ones are staying safe in this very difficult time, as safe as possible, taking recommended precautions and staying healthy. And to those that are ill and suffering, I wish you the best care possible. A little bit about myself before I get into the material. I've specialized in working with people who struggle with problematic substance use and other addictive and risky behaviors for almost 40 years. As a psychotherapist working on the front lines of addiction treatment over my career, I've wrestled with the question, why have we been doing such a terrible job of helping people who struggle with drugs? I've come to believe that the way that we think about addiction is largely responsible for our failure to effectively treat it. I believe that we need to adopt a new alternative paradigm that I call a psychobiosocial process view of the spectrum of problematic substance use to better understand it. And this shift in thinking supports a shift away from our dominant approach to treatment, which is an abstinence-only approach, toward one that's based on what I call integrative harm reduction psychotherapy. And these two dominant ideas, the shift in thinking and the shift in practice, are what I will be covering over the next hour, and what I think are really essential to our being able to more effectively address the addiction crisis that we're facing in this country. This webinar is an introduction to a body of work that informs comprehensive addiction and trauma treatment that we offer at the Center for Optimal Living in New York City. And it's also the basis of a 3-day intensive training that this is really just giving you a small taste of, that we have actually given in 18 countries around the world. It's just an example of the growing interest in this work. So this webinar is sponsored by Foundations Recovery Network and the organizations that you see on the slide. You can submit a question at the bottom left of your screen at any point during the presentation. In terms of resources, you can find a PDF of the presentation and additional resources under the headshot image located on the left of your screen. And for help or assistance, please email Melissa Pongaro at mpongaro@naccme.com. Regarding NAADAC credit information, to receive credit, you must watch the program all the way through the Q&A section at the end of the presentation. Do not leave the console. Please continue to stay on the platform and you will be automatically redirected to an evaluation landing page. If this is your first time attending a webinar in 2020, you will need to create an NACCME account when you are first directed to the landing page. For all subsequent webinars you attend, you will already have an account and you will just need to log into it. After completion of the evaluation, you will be able to download or print your certificate. NAADAC credit is only offered for the live broadcast. So I believe that substance misuse and addiction have become one of America's most urgent humanitarian crises. And unfortunately, I am really concerned that during this pandemic, the social conditions are such that things may get much, much worse for vulnerable people who are suffering along with the rest of us. Just for example, I want us to just look at some statistics. This is a graph of the national drug overdose deaths over the last 20 years or so. And if you add up the numbers, we've lost around or more than 700,000 people to lethal drug overdose during this period. And you see that it's not just in the last few years, although that's been a peak with fentanyl coming on the scene. but overdose has been rising over these 20 years. And while we have focused largely on drug overdose, we also need to consider that roughly 80,000 people die annually in the United States of alcohol-related death. So it's all substances, including alcohol, that are at a critical level of difficulty. And these, I promise, are the last statistics I'll really be giving, but I think it's important for us to look at the scope of problematic substance use in the United States. These data are from a national survey of drugs and health that's conducted by the government, the federal government, every year. These are from the most recent year, 2018. And you see that we have roughly 20 million people who have significant substance use disorders. But there are 67 million people that binged on alcohol. That means 5 or more drinks at an occasion. And 16.6 million people are considered to be heavy drinkers. That is 5 or more drinks at 5 or more times during the last month. And while these people don't meet the criteria for substance use disorder, this is 80 million or 90 million Americans that are engaging in very risky behavior that has significant public health consequences. So all total, we're talking about at least 100 million Americans are engaged in problematic substance use. And only 3.7 receive treatment, and that's treatment of all kinds. So only a tiny fraction of people that are struggling are actually receiving treatment. And I really believe that we need, and we're in the midst of a scientific revolution in the field, meaning a shift in our paradigm, a shift in our thinking. Because I think that the problem is related, as I suggested before, to our dominant thinking about addiction as disease and moral failure. And that these ideas are wrong and are largely responsible for this failure. These ideas are soaked into the fabric of our society. We've all grown up with them. We've been taught them implicitly and explicitly. And they have contributed to limited support for appealing and effective help. They also have contributed to this culture of stigma, not in my backyard. We think about people that struggle with these issues as somehow in very negative terms. And then all of this has supported, I think, a devastating war on people who use drugs that has caused more harm to people who use drugs than drugs themselves. What's the solution? This idea that I have of a psychobiosocial process model is a kind of rehumanized view of how we understand addiction and people who struggle with addictions. And we also need to shift from that criminal view of drug use towards seeing drug use as a health and human rights issue. And these shifts in thinking will lead to a whole social revolution or a shift in the way that we regard people's struggle throughout society. And I think that a harm reduction frame is essential. And I'll be breaking that down as we go through. And I think about a culture of stigma that we need to shift toward one of what has been called compassionate pragmatism. That is, efforts to reduce suffering for these folks that are suffering, but grounded in pragmatism. That is, continually evaluating what we're doing in terms of what's working and what's not working. And that's really the essence of a harm reduction philosophy. So let me say a few words about a client of mine that I've actually been seeing for about 6 years. She came to me, Valerie came to me about 6 years ago. She's a mother of 2 children. She had been the super mom, head of the PTA and the fall festival at her kid's school. And she told me that in that first session that she was injecting Dilaudid, which is a powerful synthetic opiate, and had been doing so for the last several years, 4 to 5 times a day. And she told me that the only reason she reached out to me was because she knew that as a harm reductionist, I would not necessarily require that she stopped using drugs in order to be in treatment with me. And that, I think, is the essence of a harm reduction shift. That we don't require that people commit to stopping their behaviors in order to receive help. She also told me that while she, quote, loved injecting Dilaudid, she also felt tremendously conflicted. She was concerned about being dependent, about being discovered, and feared that if she was discovered, she might lose her children. She was in a constant state of tension and fear, and yet she was caught in this dilemma. On the one hand, she really hated using, and on the other hand, she loved using. And so the question that we began to explore together was, why did she love drugs so much that she would risk losing what was most important to her, you know, her children and her family? And we'll come back to that. But that dilemma, I think, is her version of a dilemma that I think the majority of people that struggle with problematic drug use experience one way or another. And that dilemma, I think, is where we need to meet people. Because, in fact, most problematic substance users who are concerned about their use are not willing to commit to stopping at the point that they become concerned. And another important fact is that many people who struggle with drugs have multiple addictive behaviors, and they have different goals with them. So a person might identify crystal meth or heroin or another drug as the primary problematic behavior and be interested in stopping, wanting to commit to abstinence, but not experience other drugs or other behaviors such as gambling as problematic. So they may have different goals for different addictive behaviors. And in fact, for most addictive behaviors like eating and sex and shopping and internet use, abstinence is simply not an option. So this all suggests that we need to have a way of meeting people, intervening with people that doesn't require abstinence as the ticket to get into care. And in fact, I think we are living in a culture that I think is dominated by what I've called the tyranny of abstinence-only. It's, you know, that is, once we identify that somebody is significantly problematic, we immediately assume that they need to stop. And often they need to commit to stopping in order to get into treatment. That's essentially what an abstinence-only approach is based on. And this, I think, emerged out of Jelinek's disease model, which was introduced in the middle part of the 20th century, and now I think it's being supported by the National Institute on Drug Abuse's addiction as a brain disease model, and it really pervades our culture. But I would suggest that it is not supported by evidence. Jelinek's disease model was not a scientific model. It was based on a survey of AA members. And there are many very prominent scientists and brain scientists who believe that NIDA's brain disease model is wrong. So there's a lot of controversy about this. But that's one way of thinking about it. So how might we understand why people that engage in seriously problematic behavior are not ready to stop in spite of the fact that they're suffering? And these folks, Prochaska, Norcross, and DiClemente, gave us a model, a way to understand this. Back in the 80s, they did a massive study of successful self-changers, and this was published in their book, Changing for Good. Each of these folks have written since then and elaborated on this theory, and they came up with this idea that successful self-changers go through a series of stages before they become motivated and ready to take action around positive change. It's known as the stages of change model. You look down at the bottom, looking at pre-contemplation, we see the largest number of people may not really think that their behaviors are problematic, so they're not thinking about change. But once they become concerned, conflicted, notice that there is something problematic, they move into this contemplation phase. Now, there's a lot to think about. You know, in what way is my behavior problematic? Do I need to change it? Why is it so difficult to think about changing when I'm concerned about it? So there's a lot of work that needs to be done. Once people become clear that they do need to make a change, and they become clear about the change they need to make, they still need to move into the next stage, which is preparation. How do I go about making the change? Like, what approach do I take? Who's my support system? You know, is it inpatient, outpatient? Is it self-help? Can I do it on my own? And once people have prepared the pathway, they've prepared a plan, now they're motivated and have a direction to take to move into action. So you'll notice that in this model, the majority of people who are struggling with problematic behaviors are in pre-action stages of change, like Valerie, who I just told you about. Now further, they looked at people who engaged in 15 different high-risk behaviors. And what they discovered was that at any point in time, over 80% of people in each group were not ready to take action. So what this work does is it really normalizes that it's not just people who use drugs, but it's all people, all of us. And think about all of us who are struggling with our own health-related behaviors, exercising, diet, taking precautions, you know, not to infect ourselves and others in this pandemic, how difficult it is to fully commit to the things that we know we should be doing. So most people are not ready to stop, and now we have an idea, a way of understanding that. Now let's think a little bit about what is addiction, or what we call addiction. And I think it's real important to consider that addiction is an experience that is characterized by craving, compulsion, the experience of loss of control, and being unable to stop in spite of negative consequences. And Valerie experienced all of that. And I think most people from different points of view, different perspectives, backgrounds, tend to agree on the core experience of addiction. But one thing that I'd like us to consider is, isn't this a set of experiences that are on a continuum with universal human behavior? So this is just a question. Is addiction something that other people struggle with and the rest of us don't? Or are we really talking about an experience that's on a continuum? Just something really important to think about. And what we know, and I think what is increasingly being accepted, is that substance use does in fact exist on a continuum of severity, from not using at all to using in ways that are safe, experimental, recreational, maybe becoming a bit more problematic with binges and heavy drinking, as we saw in some earlier slides, and then moving into substance use disorder, which is where there are really severe consequences. One thing that we know, and we know from our own experience and from observing others, is that typically people move up and down the continuum. It's not like once you're there, you're stuck there. So, I mean, this raises questions about how do we understand addiction? And what I'd like to suggest is that the map is not the territory. That's what this scientist Korzybski said. In other words, we have different models, different ways of understanding that are attempts to kind of get at the nature of something. But there are many different ways to possibly think about it. And each of these models may be useful in some ways and not so useful in others. And also these models really shape our perspective. They shape what we do. They shape how we treat addiction, for example. So I'd like to run through some of these models. The National Institute of Drug Abuse says that it is a brain disease because drugs change the brain. They change the structure and how it works. And these can be long-lasting. I think that the disease concept historically was a very positive attempt to shift away from the moral model, that is that people were bad, addicted people were bad, to thinking of addicted people as being ill, sick, and deserving care and treatment. And I think that in that sense, it may be a very useful framework. But I think it also is problematic in that I believe it closes down the complexity that, of course, there are brain changes, but there's a lot more going on that we need to consider. So let's consider that biology becomes meaningful and becomes wrapped in multiple meanings, such that addictive behavior carries or expresses multiple meanings, often simultaneously. And these meanings may be in or out of awareness. Some people know why they are engaging in this behavior. It helps me with my anxiety. It helps treat my trauma symptoms. Whereas other people may be completely unaware. Like Valerie, for example, she knew that she loved injecting Dilaudid, but she didn't know why. And our work together was designed and focused on helping her discover what that love of Dilaudid was about. So from this point of view, behavior or addictive behavior may be a kind of language that people speak when they can't really articulate their feelings, the meaning that the behavior has in words. And our job then is to help people discover meaning, put words to it so that they can actually act on it in possibly more effective and healthier ways. From this point of view, we might consider that what we call addiction both expresses something and disguises it. So there's meaning that lives within this addictive experience. And there are a number of different ideas that have been floating around in the psychological world, such as multiplicity. And this idea captures the notion that we would like to think of ourselves as one unitary self, but in fact, we often experience and feel ourselves and function as if we're many different selves kind of coexisting. So there may be the self, the part of Valerie that wants to save her family and stop using drugs, but there's another self that lives within this addictive experience that loves injecting Dilaudid. And if we can consider that there may be multiple parts of us, multiple aspects of us that actually have different needs, different motivations, etc., that can open up a kind of exploration. Another idea is of self-states. We experience ourselves in different ways, in different contexts, so that there's our parent self, and there's our child self, there's our industrious work self, and there's our goof-off, lazy self. So we might also wonder, what is the self that gets expressed around drugs that can't be expressed around sobriety? And then there's this other model of good me, bad me, not me. The good me is the me that wants to please my family, wants to please society, wants to live up to the values and the ethics and the norms that are rewarded. Maybe the bad me are the parts of me that, don't fit in with the requirements, the values of my family, and they've been punished so that I experience them as bad. And then there are the parts of me that are not even acceptable to talk about, which may be disowned, dissociated, split off, so that I don't even really know about them. So all of this may be living in that addictive experience. And to the extent that this is true, the addictive behavior and the urges to engage in the behavior may be a kind of entry point for an exploration and a rediscovery of those parts of me that are living in that addictive netherworld. And so to the extent that this is true, we actually want to invite people into our healing spaces, into our therapeutic spaces, into conversations, such that we can actually help people do this work of discovery and ultimately reintegrating those parts of themselves into their own experience and into their relationships. Now, we could talk for a long time about this, but just let's consider some of the reasons that people use drugs. Fun, pleasure, liberation. And it may be that in a life that is devoid of fun, pleasure, and liberation, such as what we're all living under right now during this pandemic, the fun, the pleasure, the liberation associated with drug use might be very, very compelling. Self-medication of suffering. We're all suffering right now. So we all may be vulnerable to turning to substances or other addictive behaviors to try to kind of comfort and care for ourselves, mute that suffering. Regulation disorder. It might be that when we're overwhelmed by feelings that we just find too much, we don't have the skills to be able to contain or manage, we may turn to a substance to try to sort of turn down the intensity of that emotion. As I said before, it might be expressing these dissociated parts of us. Drugs can become a part of our identity, even if it's a negative identity, or it can help people feel part of a group. It can be a way of expressing something interpersonally. That maybe I have trouble expressing my needs and feelings when I'm sober because in my family I was never really allowed to express those needs and feelings. So when I use a substance, it's kind of like a symbolic way of expressing, I'm angry at you, rather than expressing it directly. And that also gets that relational meaning, or rebellion against the inner critic. We all have an inner critic, a part of us that criticizes, that judges us. Sometimes that critic can be very severe, and to the extent that that's true, sometimes people discover that having a substance, getting loaded, getting high, puts the critic to sleep. So there is this temporary feeling of, freedom, I can be myself. I don't have to feel so guilty and anxious and ashamed. The problem with that solution is that when you come out of the high the next morning, the critic is often waiting to attack, to attack you for having rebelled against the critic. So it can be that vicious cycle of using and then feeling depressed and terrible, and then using and feeling depressed and terrible. These are not necessarily the best solutions, but often they are solutions that are the best for the moment. And it can express self-destructiveness. When people feel very despairing and very hopeless, they may feel like maybe I'm not even worth living or valuable enough to hope, to have the things in my life that I want. So I might as well hurt myself. Body needs, pain, fatigue, etc. And then shame and guilt. Shame and guilt can often propel problematic drug use. Because society shames, and because using a drug makes me a criminal under prohibition, or because the reasons that I'm using drugs are because I have needs and feelings that I feel ashamed of, that I can't express directly. So just using kind of can intensify the feeling of shame and guilt, which can then make me want to use even more to try to get rid of those feelings. So there are many, many more reasons that I would invite you all to think about. But once we shift from disease to meaning, it opens up all sorts of possibilities. Gabor Mate, who is an addiction doctor who wrote some very important books, and he's got some wonderful videos, he says the question is not why the addiction, but why the pain. And I love and respect Gabor, but what I would say is the question is both why the addiction and why the pain, because as people are using substances to try to manage pain, other things begin to happen. But what Gabor is, and I'll get to them in a moment, but what Gabor is really focusing on is that there is a significant association between trauma and what we call addiction. Trauma is an experience of life-threatening or self-threatening or soul-threatening events that overwhelm our ability to manage. And so what we often have to do to deal with trauma is dissociate, disconnect from the experience, the fear, the parts of ourselves that were associated with that trauma. And another part of the consequence then is that we have difficulty developing our ability to manage or regulate our feeling states. So people who have experienced trauma often feel overwhelmed by emotions or feel cut off and shut down and dead. Trauma also contributes to people feeling very mistrustful of others or of the world, feeling tremendous shame and self-hate. Why did I allow myself to submit to that? And so all of these aspects of trauma can contribute to a tremendous vulnerability to turn to substances in an addictive way to try to cope. But when you turn to a substance over time to cope, and it helps, you can actually develop deeply ingrained what are called overlearned habits that get networked into the brain. And this is an alternative to the disease model, this overlearned habit model, that is another way to understand why addictive behavior can be so compelling and so difficult to change. But to the extent that this is true, I'd like to think about how biology, that is the effect of the drug, the meaning that it has that can make it reinforcing, and the social context that's contributing to the suffering, actually come together in that conditioned urge. We'll come back to this because that suggests to me that the urge to engage in the behavior can be an axis of change. If we can interrupt addictive behavior at the site of the urge, we can then create a space to think, to reflect, and to think about alternative ways of caring for ourselves. So that's a very important idea that we'll come back to. And finally, another model is the social determinants model, that the legal context actually contributes to shame and guilt and anxiety, and both the criminalization and stigma can contribute to what Bruce Alexander calls social dislocation. That is, people feel ashamed and anxious and scared, so they hide out. They disconnect from positive social support. And all of that can contribute to escalations of anxiety, depression, hopelessness, and increased substance use and suicide and overdose. So we need to think about the social context. And I think in this moment of this terrible pandemic, we're all experiencing the power of the social context, the environmental context, to affect how we feel and maybe contribute to acting in ways that are not so healthy or maybe even severely problematic. So I put this all together in a model that I call psychobiosocial that actually considers that all of these factors, biology, psychology, relationships, social context, kind of come together. They're all intertwined in a way that suggests that we need to be considering all of them when we try to understand a particular person's addictive process. And here's a schematic way to think about that. We could say that in the upper left circle, all of the things in that box, that circle that I call vulnerabilities, are highly associated with addiction. But none of them cause it. Because even if you've got a genetic loading in your family, you're not 100% sure to become addictive. Or people with histories of trauma don't all develop addictions. Deficits in affect regulation, etc., difficult social circumstances. But some combination of those, for each individual, interacts in a way that leads people to be highly vulnerable to using a substance and finding it pleasurable for its neurochemical effects, its personal meanings, its symbolic functions. And as you begin using over time, a whole set of other consequences kick in. There are changes in brain receptors and neurochemistry. There is that social stigmatization that can lead to isolation. there are physical and cognitive deficits that occur over time. And there's that conditioning, all of which may increase suffering and increase the vulnerability to use the substances or engage in addictive behavior. Now, what we get from this complexity model is two things, I think. It helps us understand why people would continue to engage in these behaviors when there are increasing negative consequences, because actually the behaviors are working. So that helps us understand, for example, Valerie's continued use, her love of Dilaudid, in spite of the negative consequences that she was experiencing. It also suggests that if all of these variables are intertwined, wherever a person is willing, ready, and able to begin to get some help, maybe to address the trauma, or maybe to address some of the physical consequences, or maybe to address, poverty, their difficult life circumstances, making positive changes there is going to shift people's relationship to the substance or the addictive activity. So any positive change will actually sort of shift the negative cycle and may begin a positive cycle of positive change. Now, back to Valerie, when we did our urge surfing, that is, helped her sit still with the urge and began to look inside of it, what I call unwrapping the urge, what we discovered was a history of physical and sexual abuse that started with physical and verbal abuse by her dad. There was sexual abuse by a stepbrother. She was raped several times early on as a young woman, and this contributed to a whole host of trauma that left her vulnerable to using substances when she was a young woman. And although she stopped using for many years, a relatively recent back injury brought her to a doc who gave her some prescribed opiates, and that kind of mushroomed back into her current pattern of use. It was as if the trauma that had never been resolved now came back to life in the drug use. And that brought her into treatment, and she and I were able to focus for 18 months while she continued to use substances on processing the trauma. And once we had done some sufficient process work with the trauma, she felt significantly relieved, and she felt ready to detox. She went off to detox 4 years ago, got off the Dilaudid, and she's never looked back. She has had no difficulties with substances since then. So now I want to shift to what is harm reduction and how does that fit into this picture. And we'll talk about some basic harm reduction strategies. So if most people who are struggling are not ready to stop for complex reasons, but they are struggling and want help, I think the harm reduction frame is a kind of attitude, it's a set of ideas and strategies that frames how we might engage people wherever they are ready to begin a process of positive change. Dan Bigg famously came up with this concept or phrase, any positive change. So we can support, this is the central shift, to support any reduction of drug-related harm or suffering that does not require a commitment to abstinence. All it requires is a desire to feel better, to make some positive change in one's life. And therefore, we might think of this as an umbrella concept that can subsume working towards safer use, reduced use, moderation, and abstinence. This is a misunderstanding many people have, that it's harm reduction or abstinence. In fact, abstinence is the best harm reduction outcome for many people. But what the harm reduction shift says is that we don't need to begin with a commitment to abstinence to help people get there. And what this does, in my mind, is it extends the reach of our traditional treatments, of all of the good things that are out there, to this large group of people that we have not been effective at engaging and helping. Now, what we can do is meet people where they are, wherever they are ready to begin their process of positive change. and to meet them as unique individuals in unique social circumstances. So that rather than having an agenda that we impose, we need to be radically committed to meeting people as unique people, to create a space to help discover who they are and help them discover what's true for them, so that we can then offer help that is actually relevant to their needs. We don't need to know the destination to begin the journey. So I think about curiosity, respect, acceptance as, primary values and qualities that we need to bring to this encounter. Now then another shift is toward small incremental change and affirming every positive change. So the abstinence-only approach has said, you need to basically jump to abstinence. What this approach says is we'll begin wherever you are ready to begin your positive change process, and we can work toward that ideal goal in small increments. Now, if we can support quantum change, that would be wonderful. Some people are just ready to quit, but most people really have to go through a process of working toward those ideal positive changes. So if substance use is on a continuum of risk, then this approach says, let's help people move down the continuum toward reduced risk, reduced harm, increased positive change. Small incremental changes then need to be affirmed as successes and acceptable goals. And many of them may precede, as with Valerie, the actual focus on the substance use. There may be a number of issues that need to be addressed before we can actually address the problematic behavior directly. And let's consider how all complex behavior changes. If we want to develop a really great exercise program, we don't just sign up for the marathon. We first need to buy a pair of running shoes. We need to do a lot of research. We need to find the time. There's a whole process of small changes that move toward those ideal goals. And so we can support people in safer routes of drug administration, alternative safer substances, reducing the frequency, reducing the intensity. There are a number of different ways that we can go with this. And finally, another central core part of this is collaboration. We shift from this sort of top-down, authoritarian prescriptive perspective. I know what your problem is, and I know what you need to do about it, and you either do it or I won't treat you. And that approach, I think, has been traumatizing for many people. Whereas we say, let's meet you where you are, and let's work together as a team, respecting that you have expertise in your life, you have skills, you have strengths, and we want to support you on your journey toward positive change, healing, and growth. It's a whole different way of shifting things. Pat Denning says this: now we can become therapeutic teams working together. And this is inherently empowering to people. I can tell you that, when we shift to this approach, we've now got a motivated partner in this positive change process, as opposed to somebody that we need to bang over the head to get them to do what we want them to do. Now, finally, harm reduction is also a social justice movement, because stigma and the war on people who use drugs are the greatest harms associated with drug use. Millions of people's lives have been destroyed. People use drugs, their families, their communities, for this failed war on drugs. We all know this is the case. And it's in the face of this that we have this greatest humanitarian crisis around addiction and overdose. So harm reduction is first and foremost a global movement to restore and protect basic human rights of people who use drugs that are often violated by prohibition and stigma. So that, I think, is a bigger picture that we all need to be concerned about. Now, I'm going to get very quickly to some interventions, public health interventions, and then share with you a little bit about a psychotherapy counseling kind of helping process that I think everyone can think about how to incorporate into the helping work that you're doing, whether it's with family, friends, loved ones, clients, patients, etc. All of these interventions are public health interventions that have been highly associated with reducing the harms associated with drug use, the most highly associated. Honest drug education is a key. Many people have not been educated about the harms associated with drugs, with drinking. I can tell you, working with many highly functional, bright people who get into trouble, that they just haven't had the education. They don't know about what the risks are. So we need to begin by talking with people and educating them about real risks. For example, there are special risks associated with using certain drugs during this COVID-19 pandemic, and people need to be educated about that, just like we all need to be educated about how to keep ourselves, or at least reduce the risks of infection. Narcan, the overdose prevention medication, should be in everyone's pocket, everyone's backpack, everyone's car. Narcan has reversed millions of overdoses and is not giving people permission to use drugs. It's actually enabling people to stay alive so that they have an opportunity to address their problematic drug use. Opiate substitution therapy, medication-assisted treatment, methadone, buprenorphine. In other countries, they're doing heroin and morphine. These are all keys. They are the most highly associated interventions for helping people that are opiate users or opiate dependent stay alive. And being maintained on a substitution medication is not the same as addiction. It's like insulin. It takes care of the biological imbalance and need, and then we can actually deal with the addictive issues. And some people may choose to be on these medications indefinitely, and some people may choose to stabilize and detoxify and go a drug-free route. So again, we need to be highly individualized. Needle and syringe exchange programs have been the most highly associated with reducing the spread of HIV and AIDS, and supervised injection facilities give people a safe space to inject under medical supervision, and and have been widely accepted in Europe and Canada, and with millions of injections, there has not been one lethal overdose. They are also highly associated with people then going on to become meaningfully engaged in healthcare, in addiction treatment, in mental health care. For example, in Vancouver, Insight, the well-known injection facility, has a detox on the second floor of the supervised injection facility. So many people come in and then move into addiction treatment. Now, let's talk about some basic principles with what I call harm reduction helping. And while my work has primarily been about psychotherapy and counseling and substance use treatment, I think these principles can also apply to families who want to help their loved ones, friends who want to help their friends. That is, establishing relationship, establishing connection seems to be one of the most important antidotes to addiction. In fact, Johann Hari, a journalist who wrote a book called Chasing the Scream, came up with this wonderful phrase that the opposite of addiction is connection. I alluded to this before with Bruce Alexander's social dislocation theory. If we cut people off from sources of positive social support, they feel worse, they get worse, and their behavior tends to become more risky, problematic, and potentially life-threatening. So what we want to do is frame our helping in these core principles. We're not going to require that you commit to stop your behavior in order to be in this helping relationship. That enables us to start where you are, with respect, with acceptance, with compassion, with support. And now we can begin thinking about what small positive changes are you ready to begin taking on, considering, as experiments. And we're going to work together as a collaborative team to figure that out and help you figure out, what goals and what approach to change best suit you as a unique individual. These are the two texts. My book on the left is a book that has wonderful case studies from different therapists that actually bring you into the room and show you how different people do this work. And I wrap those case studies in commentary about some central issues. Pat Denning and Jeannie Little wrote this wonderful book that's kind of more of a textbook that really lays out a lot of the work in fine detail. Here's the model that I've been developing, and I'm just going to talk through it very quickly. And for those of you that are interested, we have intensive 3-day trainings that take people through this entire model, learning different therapeutic tests, techniques, strategies, and doing skill practice and demonstrations to really learn how to bring this into your lives and into your practices. So on the top, the first task is establishing the alliance. If we don't have an alliance, whether it's with clients, patients, or with families, loved ones, we can't get to, anywhere. Like, the alliance is the foundation of any kind of effective helping. So how do we create safety? I think a primary way that we do that is with empathic listening, that is actually listening for the other person's experience so that we can reflect back to them that we're actually hearing them and that we're on the same page. And then we can talk about where to go from there. Then around that alliance, we establish a relationship. And this task is that relationship itself becomes healing. Many of people who struggle with addictive issues have had such terrible relationships, either early in life or throughout the course of their careers as drug users, that they come in with a tremendous amount of fear, of distrust, expectations of being punished, and just the fact that we can engage them in a new way with respect, compassion, empathy, actually helps people heal from a lot of that relationship trauma or difficulty. Now, once we've got our alliance and our relationship, we can start talking with people about developing certain skills to better regulate their emotions, their self-esteem, their relationships. It's like, how can you change a behavior that is, a reaction to being overwhelmed with feelings, unless you have the ability to sit still with those feelings, to manage them and contain them. So now that we can help people sit still, it becomes possible to do the fourth task, which is assessment. We want to sit still with people and help them understand the meaning, the function, the psychobiosocial factors. That is, the why and the what that's driving this problematic behavior. And as we can tease those factors apart, we can then goal set. But the fifth task is really important because, as with Valerie, most of these folks are very ambivalent about changing. A part wants to change and a part doesn't. And we need to invite the ambivalence into the room so we can actually have a dialogue with both sides. Let's say the part that wants to use is finding that using helps with anxiety. The part that wants to change is the part that doesn't want to have the negative consequences. But if we can help the part that wants to use come up with better, alternative, effective ways of managing anxiety, that's going to enhance the motivation to give up the substance and to support the part that wants to change. Now, once we've got the ambivalence in the room and we can clarify what the needs are on both sides, it becomes possible to think about what I call harm reduction goal setting, goal setting around positive change with the behavior, as well as goal setting with the issues that are driving the active use. And now that we've got some goals, we can set about coming up with a comprehensive plan for positive change that really addresses all of those factors, including the addictive behavior, the co-occurring issues, the meanings and the functions that the behavior has been satisfying. And one neat technique that we use is what we call the ideal use plan. How would you ideally want substances in your life that would maximize the benefit and minimize the risk? And that strategy is kind of a framework for helping people think about what their goals are, what their intentions are, what's realistic for me. If I want to maximize, have a positive relationship with substances, it might mean no substances, because any substances actually kick off that loss of control. On the other hand, some people can get clear that a moderate use of alcohol, abstinence from heroin or other, seriously problematic drugs becomes possible. But then what other changes would you need to make in your life? What other issues would you need to address in order to effectively achieve that change with your substance use? And since we're closing in on just having a few minutes left, I wanted to say a word about this technique that I've alluded to, urge surfing, that I think is really a key technique for any kind of behavior change process, addictive behavior or other problematic behaviors. And then there are just a few questions that I had, sort of frequently asked questions that I thought I would briefly address. So if the urge is the access of change, imagine that, or consider that any action, whether verbal or physical, begins with an urge. And if you can catch the urge, the feeling in the body, the impulse to speak, and you can sit still with the urge, just kind of hang out with it, you can actually interrupt that addictive process. And sitting still with the urge requires bringing mindful awareness to the urge, noticing that with acceptance and compassion, where does that urge live in your body? How do you experience it? Is it a sensation, a thought? Is it in your chest? Is it in your mind? Is it an image? And what if you could bring mindful, accepting awareness to that urge and simply breathe with it? So you can turn down the intensity of it and sit with it. And practicing urge surfing, like practicing any skill, actually improves your skill over time. So this is something that you can do without any commitment to changing the behavior, but just to put some space between the urge and the action. It improves your ability to tolerate the distress. You can now sit and think. You can reflect on your choices. You can think about unwrapping the urge. Why do you want to engage in this behavior? You can look at your ambivalence, and you can think about, is there a better way for me to respond to this moment, caring for myself, than engaging in this risky, problematic behavior? And that alternative can be a way of rewiring that addictive process, inhibiting the old addictive habit and working in a new, healthier way of caring for oneself. And we might think about these alternatives working within as the recovery process. So this is a question that I hear all the time in almost every training and workshop that I give. Can you really help someone who's high during the session? And I think we might think about analogies like depression, like anxiety. The old disease model has us thinking in this kind of more binary way. If you're intoxicated, you can't benefit from therapy. But in fact, if we shift to thinking of substance use on a continuum of severity, then I think, like with anxiety and depression, we actually can work with many people effectively when they're intoxicated. And obviously, there comes a point when people are so intoxicated that it derails any possibility of a therapeutic dialogue. On the other hand, we also need to be thinking about if substance use is meaningful, why did the person come to the session intoxicated? And might that be an important communication that maybe they couldn't make it without using a substance to get there because they were so depressed. And in order for us to ferret that out, we need to be willing to consider exploring that with them while they're intoxicated. Also, by accepting people in the session, we're sending a very powerful message that we care about you, we are radically accepting of you, and we're going to work together to figure out, what this is about for you and what the best way to respond would be. So, for example, if somebody is so intoxicated that it's really risky, they might have come in to really ask for help, and we can then get them the help they need to help them stay safe and alive. So I'll just close by saying I want to thank all of you for listening and for being open to considering these ideas, and consider how you might integrate them into your own lives, your own settings, and so on. And just consider, as this final slide says, harm reduction saves lives. And when we can help people stay alive and safe, all good things become more possible. Thank you very much for spending this time with me.